DigiNeuro from Endoscopic Society of India and DigiNeuro, a digital initiative by Health NU. Today's topics are ETV difficulties and management and opening of CSF pathways, septoplasty, aqueductoplasty, trapped fourth ventricle and temporal horn, lamina terminalis, fenestration. This webinar is coming to you from digital initiative of Health NU. Health NU is collaborated with New Link Company Limited, Japan. We have a mission to fulfill unmet medical needs. We have AmNurite, the first combination of amitriptyline plus mecobalamin in neuropathic pain and in migraine. We have AmNurite 5, 10 and 25, pain relief, feeling good. We have AmNurite beta when migraine is not controlled by one drug, amitriptyline and propranolol combination, AmNurite beta 520 ER and AmNurite beta 1040 ER. We have the first pharmacological combination we launched for neuropathic pain, where pregabalin is converted into sustained release form to match pharmacokinetic profile of amitriptyline. So AmNurite P for 24 hours of pain control. We import mecobalamin injection from Japan to give you highest quality NeuroRite injection for neuropathic pain. We have launched a new 2.5 milligram strength of clobazam, first time in India. Add clobaz 2.5 milligram, 5 milligram, 10 milligram to add flexibility and add control in epilepsy. Recently, we have launched a vitamin therapy for migraine recommended by American Academy of Neurology, Brentamine, which has riboflavin 200, magnesium 200, and CoQ10 10 milligram for special population like migraine patients, school-going children, and to add on to conventional therapy of migraine. This webinar and all our past webinars are available on DigiNeuro channel of YouTube. So tomorrow this webinar will be uploaded and you can see it there in case you missed part of this. I have now great pleasure in introducing our moderator today, who has put together this webinar series on behalf of Neuroendoscopy Society of India, Dr. Suresh Sankhla. He is a consultant neurosurgeon in Mumbai, in Global Hospital. He is president of Neuroendoscopy Society of India, the current president. He is also Asia Pacific in charge of International Federation of Neuroendoscopy. He has more than 120 publications and more than 30 book chapters to his credit. He has also edited 2 books. He is a faculty in national and international courses and workshops in neuroendoscopy. So we have great pleasure in introducing Dr. Suresh Sankhla as today's moderator. Our second moderator today is Dr. Professor Ashish Pathak. He is the Director of Neurosurgery in Fortis Hospital, Mohali, Chandigarh. He is former professor of the prestigious PGI Institute, Chandigarh, former consultant and pediatric neurosurgery in NHS, UK, Sheffield. He was also a former lead in vascular pituitary and skull-based neurosurgery in Kingston. Sir has been past president of Cerebrovascular Society of India and current honorary secretary of Endoscopic Society of India, former executive committee member of Indian Society of Pediatric Neurosurgery and Indian Society of Neuro-Oncology. I have great pleasure and privilege to now hand over the session to Dr. Ashish Pathak. Sir, please take it forward.
Thank you very much. It's a great pleasure to start this first of the series of seminar which the Neuroendoscopy Society has organized. And I have to thank the president, Dr. Suresh Sankhla. It is whose brainchild which initiated all this. And of course, I joined hands with him, and we plan to have a series of seminar, and we have made a plan to hold one webinar once a month, actually. So that's all planned out, and it would cover all the topics, including cranial and spinal topics, so that we have a full coverage, a holistic sort of coverage of the various topics that we have. Now we have got 2 important topics to be delivered upon today. The first one, of course, is by Professor Seow, who is going to talk of the ETV and its difficulties in management. And the second one is Opening CSF Pathways by Dr. Subodh Raju. There is an error in the naming of the topic, and I apologize for that. It should be septostomy, not septoplasty, and then aqueductoplasty, trapped fourth ventricle, temporal horn, and lamina terminalis. And we have chosen this topic specifically because the way it should be presented is to highlight the difficulties and the hard points in each of these subjects which we talk about. We also have the pleasure of having three eminent panelists with us today, and to name each one of them, of course, and to talk about them will take a long time, but to be very brief, I would highlight the role. Professor Sandip Chatterjee obviously needs no introduction. He's a well-known figure. He is professor and head of neurosurgery in Wemans and Park Clinic, Kolkata. He is chairman education committee of ISPN, and he has got huge number of publications as articles, as chapters in books, and of course he has edited books. He was very humble not to allow me to talk more about him, so that is all what he has provided me to give his introduction. And the second person is no less. He is Dr. Ramesh Theegala, who is a very young enthusiast in this field. And he is professor of neurosurgery again in Ashram Hospital. And he is also assistant professor of neurosurgery at AmNurite Institute of Medical Sciences, Kochi, in southern part of India. He is very keen in innovations, and he has developed a cost-effective biodegradable neuroendoscope training model, which is really very interesting. And he has also has huge number of publications. He is a WFNS Traveling Fellow Grant awardee, and he has got many other awards to his credit. The third panelist, of course, is Dr.Suhas, who again is a well-known figure in our society. He is professor of AmRita Institute of Neurosciences. He has been trained from Israel and received fellowship from that country. He has also attended huge number of workshops and conducts workshops, and he has got huge number of publications, and is purely dedicated as professor of pediatric neurosurgery, and he is very much into neuroendoscopy. And again, his interests are very much focused, and we often see him giving his thoughts and innovations. With this introduction, let me now also sort of request our president, Dr. Suresh Sankhla, to welcome and start the webinar, please.
Thanks. Thank you, Ashish, for introducing the whole webinar series and our plan to this education program, as we have really proposed for our members and other neurosurgeons. Thank you, Mr. Deepak Naik, for helping us organize this meeting and the webinars in this month and the next few months. On behalf of the Neuroendoscopy Society of India, I would like to welcome our speaker, the esteemed panelists, senior members of the society, and all other participants who are present for this webinar today. It is my great pleasure to introduce my friend Wan Tew Seow, who is the first speaker of this webinar. Wan Tew is a senior consultant at the Department of Neurosurgery at National Neuroscience Institute, Singapore, of which he has been the chairman between 2015 and 2019. Wan Tew is basically a good pediatric neurosurgeon, and he is also a consultant pediatric neurosurgeon at the Children's Hospital, Singapore. Wan Tew has several publications, peer-reviewed journals to his credit. He has also written a huge number of book chapters and books and so much. But what is more striking about him is that he's so much interested in teaching and training the people. And he goes all around the world teaching and as a faculty member for the international courses and workshops in pediatric neurosurgery, as well as the neuroendoscopy. So it is a great pleasure to have you, Wan Tew, today here. and his topic on the difficulties in the ETV. One would like to really look forward to hear you. Want you, all yours.
Thank you very much, Suresh. Let me just share my slides. Yeah, it's a great pleasure to be here, to be the first speaker for this wonderful course that the Indian Neuroendoscopy Society is organizing. And, thank you very much for all your comments. Actually, I feel privileged that I can actually be asked to speak here. Right, so you have given me a topic talking on ETV difficulties and management, and we'll see how we go about doing it. I also want to just put special mention to my friend Gianpiero Trimborini, who has actually provided me with some of the slides that the videos that I'm using in this talk. Okay, so let me just get going. So basically, I think we all know about what ETV or endoscopic third ventriculostomy is. It's an alternative to shunting for treatment of selected cases of hydrocephalus. And now it's been used for at least past decades, and it's been really good reports about its long-term outcomes in the literature. So what is endoscopic third ventriculostomy? I think most of us know, but basically it involves the creation of a fenestration, other endoscopic visualization in the floor of the third ventricle, and including the liquid membrane anterior to the mammillary bodies. And usually you use a blunt probe to make the fenestration, and this fenestration is then enlarged with a balloon catheter or some other type of forceps, and the resulting stoma communicates the ventricular system with the basal systems, and then that's how CSF is then released out and for absorption. So what are the indications? Any form of hydrocephalus that's purely obstructive in nature, and this is where some of the controversies may exist, but really it's really the obstructive type, meaning that you need to release it out into the subarachnoid space, and the area of obstruction could be one or multiple, and it has to be located between the middle third of the third ventricle, right, and then into anywhere along the fourth into the prepontine system. And these are type of cases that would be treated properly and easily with ETV. Now, ETV generally is a straightforward procedure. Maybe it takes about 15, 20 minutes from skin to skin. And basically, as the video shows, you just go into the lateral ventricle, from there into the third. And then from there, you go to the floor, make the small opening. And here we usually use a blunt probe. And then after, with the holes open, you put in a Fogarty balloon, you blow it up, and depending on the type of balloon you use, the one that we use is round, so sometimes you have to fiddle with a little bit to get to the middle, and usually you can make a hole big enough, and then you take a peek through the opening, you see the basilar artery, you know that you're in the subarachnoid space, and therefore this is what it takes. So that's a straightforward routine. So what are the difficult ETV cases that we are talking about? Well, I think it's many diseases, and we see developmental anomalies, we see tumors, the ventricular anatomy is distorted, and this is where the surgical technique can become difficult. Right? There are a lot of anatomical variants. It means it's not your usual anatomy. This could be a small or tight foramen Monro, the presence of interthalamic adhesions. Floors can be very difficult. You can have thick liquid membranes adhesions below the floor, which may not be easy to break into. You may see anomalies of basilar artery and perforators, which would make the surgery much more difficult. And especially if you are considering operating on cases of myelomeningocele, you will find many anatomic variations. And of course, the presence of bleeding makes the procedure very difficult at times and even impossible. And then of course, the other one that actually, the other indication that can make surgery difficult is what they call redo or re-ETVs because the presence of scar tissue. And then there are the technical issues that arise because of how you place your burr hole and how you proceed with the surgery. So these are some of the difficult situations that may make the surgery difficult, and I will go and explain as we go along. So let's start with technical issues. I think the most common problems that arise that can make your operation very difficult is actually how you place your burr hole. Right? If you place the burr hole too anterior, you might have a problem going into the foramen of Monroe, right? And if you place a burr hole a bit too posterior, you may also cause some damage. And so this is the type of issue here. You can see you put in this case, the burr hole is placed a little bit too posterior. And then when you go in, you think that, oh, what is this? It looks like it's a bit of a problem. You're not sure. The anatomy is a bit blurred. And then actually it's only when you really do an inspection that you realize that actually you've gone a bit, you started off too posterior. Now you've gone, now that's what you're seeing was the anterior part, the floor of the anterior horn. And then so as you retract and push the endoscope laterally, more posteriorly, right? Because you had a anterior trajection, now you can see the foramen Monroe. And similarly, if you are coming in from too anterior, right, you may actually see the posterior part. Of course, you should be able to guide yourself using the correct plexus, which will usually lead you to the foramen Monroe. What about foramen Monroe? So there are, of course, various anatomical variants, which I will show you, right? Most what we consider normal size in the sense that the size of the foramen Monroe is big enough to allow the tip of your endoscope to go in. And most cases of hydrocephalus, in many cases, actually, the foramen Monroe is actually much larger than you expect. So these are some of the so-called normal ones, right? Sometimes they're too small. So like in this case, actually, there is a atresia of one of foramen Monroe. In this case, it's a very congenital case where there is no septum pellucidum. You see there's only one open foramen Monroe. So to do the ETV, you actually have to go to this. You cannot go to this. This is another case where actually there was a previous hemorrhage, and you can see the foramen, the correct plexus is here, but the whole foramen of Monroe is actually closed up by adhesions, and it may not be possible to open up this foramen Monroe without causing bleeding. And then you can also get cases of stenosis, and these are the type of cases that you see very commonly in patients with myelomeningocele, where you are attempting to do a ETV. So in cases like this, if you cannot pass your endoscope through, it's virtually impossible to do the ETV. Then what about the interthalamic adhesions? Now, it's been said that actually it's only absent in about 30% of the population, all right, more in males than in females. And it's a structure that connects the medial surface of the two thalami. The function is really not known. People think it may be connection fibers, but apparently it doesn't contain neurons, just glia tissue. And the massa intermedia is often thinned out in patients with hydrocephalus because of the increased distance. And you can see this quite easily, and this is a big one seen on the MRI. Right? So usually you can spot a interthalamic massa intermedia on the sagittal cuts. Right, so this is what it looks like when you're in the ventricle. This is actually a posterior a view of the thing from, actually this is when you are doing a supracerebellar approach to a pineal region, you can actually see the massa intermedia in front of you. And the possibility of damaging or tearing the massa intermedia is actually not difficult to do, and it can result in bleeding. And of course, we are not sure whether you will get any neurological deficits or not. Right, this is another case of again, a patient with a myelomeningocele, where you're going in and you can find that actually the floor is really totally obstructed by the massa intermedia. Right. But interestingly, there is a paper in the literature talking about the using an endoscope to actually biopsy pediatric pineal region tumors. And they actually say that when you see this, it's okay, especially in children, to sacrifice the massa intermedia by dividing to have better view of the posterior ventricular structures, especially like a pineal region tumor. And they say that in the children that they have actually done, they have not seen any cognitive or neurological problem. And because their series was only in children, they recommend that you can only do it in children. And sometimes when you go into the third ventricle, you also can see the presence of blood vessels. and adhesion bands crossing the ventricle. And these also can be inevitably torn. And you usually see these sort of structures in cases that had previous surgery or hemorrhage before. They are almost like inflammatory structures that appear later on. And of course, they bleed quite easily. And so those are the walls of the lateral ventricle now. And we go into the third ventricle, you will also see differences now. The floor of the third ventricle, the area that we are going to make a hole in, is actually part of the hypothalamus. This is the tuber cinerea. And you may actually therefore injure some of the hypothalamic nuclei as you do the perforation and the fenestration. And of course, the anatomy will depend on the age, the duration of hydrocephalus, the associated condition, example, myelomeningocele, as we mentioned, previous intraventricular hemorrhage, the presence of a tumor, and so forth. And you can see here is quite a virginal floor of a very thin up floor of a infant, whereas this is a floor that shows a lot of debris, which is what you see with previous intraventricular hemorrhage. And the third floor is anatomy is actually very, very, different in every case. Just like the face of a person is different. So you can see in this particular one, the floor is actually displaced downwards, right? So that may make the attempt to actually make a hole in the floor much more difficult. Similarly, this one is even more extremely displaced downwards, and you can see, right, the basilar vessels there, right? And so the floor is here, and actually trying to make it down because of the way our blunt probes have to come out through the ventricle, through the scope into the floor. You can see trying to tell me, it looks as if like the floor is actually your probe is bent, but actually it's the refraction at the edge of the endoscope because of the way the floor is actually displaced. And then in some cases, what seems like a routine case, you can find that in this case, when you look at the floor is bulging out. It's as if like, the floor is, maybe the hydrocephalus has been there for a long time, the floor is thin out, and when you release CSF, as you put in your endoscope, it itself may cause a displacement of the floor. And this type of bulging floor actually makes the surgery so much difficult because it's very difficult to actually make your hole. Like in this case, what I actually end up ultimately doing was actually pushing it against the sella so that you have a hard, firm surface to actually press against and then make the hole. So you can see the whole floor flaps in, and you've got to be very careful making sure that you don't injure anything else below. And so it takes a while to make the floor, and you can see also that as you make the floor, right? So there's finally you make a hole there, and there's right in the center of several area, huge big area, and even putting in the Fogarty balloon became a problem later on. So these are some of the tough type of cases that you do. I'm just showing this, just the floor, so showing you just where the floor looks like even after you make a fenestration. And then in some cases, like for instance, when you have a posterior fossa tumor, the floor is actually very short. So the distance between the mammary bodies and the sella is actually very, very little, and your risk of actually causing a damage to the underlying basilar artery is much higher. And you can see why. So like this was the case, one case that actually started. You can see that there's a posterior fossa tumor here, or even involving the brainstem. But in this case, this child hasn't had hydrocephalus yet. So you can see that the space between the subretinal space here is still, the cistern is still quite generous. But then, as the hydrocephalus progress, you can see now the space here is, the prepontine interval here is actually decreased. And so in these sort of cases, doing a third ventriculotomy would be much more difficult. So you can see this another case of a posterior fossa tumor. You can see that you go in, right? It's quite tight. I'm sorry if it looks quite dim here. You can see the floor. This one is not too bad, but what actually happens as we make the perforation is you can see the basilar artery is directly underneath already, right? Because the basilar artery is pushed forward. And in this case, you can see as we start to blow up with the balloon, as we make the hole bigger, right? You can see really the basilar artery is directly underneath there. Okay, so we're opening up second round, right? So these are the type of cases that you just have to be careful. And of course, you will get some bleeding, which, you know, we pray that you are, if not actually damage one of the perforators. So in cases of posterior fossa tumor, the basilar artery is pushed forwards and your risk actually of causing injury is quite high. And then there are flaws that are what it considers vertical. So like in this case of a Danny Walker malformation, you can see that, you know, the floor is it's as if like it's sloping downwards, almost vertical. And then in cases that have actually had surgery, so you can see that in this case, this is a child that actually had an ependymoma in the supratemporal region, but then developed hydrocephalus. You see that the floor here was okay, but as we try to do the ETV, right? And again, this is one of those where the floor then starts to just bulge out into the area, and you can see it's quite difficult to actually do it. And then you can see what happens as you try to go in, and you look in, you can see that you can't see the basilar artery clearly. There's just a lot of adhesions, and you know, it makes it very difficult even to just try to look into the subdural space, subarachnoid space. And in this particular case, actually, even though the floor actually, the opening is quite big, actually this became a failed ETV because you can see as you look into it, there's a lot of adhesions in the subarachnoid space, making it not possible to actually do a good ETV. And then the other thing that makes ETV difficult is bleeding, right? And this is the most complication, vessel injury, particularly if you damage the basilar artery and its perforators. Now, minor hemorrhage can be caused by small vessel injuries. For example, as you put the scope in, you can tear some in the cortex, parenchyma, even the correct plexus or the margin of the stoma during inflation of the Fogarty catheter. Right? Minor hemorrhage can be managed with irrigation with the Ringer's lactate. And the irrigation fluid actually doesn't wash blood away, but actually what it does is that it provides a tamponade effect on the vessel, and many times those vessels will close up. But if the bleeding does not stop, then you would consider coagulation with the bipolar or monopolar diatony. Now, another way to stop hemorrhage, especially those from the age of the new stoma opening, is to inflate the Fogarty balloon just at the level of the opening so that it compresses the edge. And you keep it there for about 15 to 30 seconds or a bit longer. And then you usually find that when you release the balloon, the bleeding usually stops. And of course, when you have done the procedure, you withdraw the endoscope slowly and make sure there's no active bleeding in the third and lateral ventricles. Now, the reports suggest that minor hemorrhage occurs in about 16.5% of cases, but actually this really depends on whether you report it or not. Now, major hemorrhage is where you're very worried, right? So because it's injury to the basilar artery or basilar perforating artery, the terminal vein, and even the anterior septal vein. And it can lead to uncontrollable hemorrhage and life-threatening situation, as you can see in the video there. And if the hemorrhage is difficult or cannot be controlled, then you should consider putting in an EVD, get out, and then do angiogram and see what else you can do. In some cases, you may need to even consider craniotomy, although it's going to be very tough. Then there are also structures on the floor that actually can make life easy. Like in this case, this is a dilocal ectatic basilar artery. So the risk of actually causing perforation is actually much higher in these cases. And these are the type of cases that you will want to see in the MRI before you even consider doing these ETVs. Similarly, you can see that when the basilar artery is very short, the number of perforators that are coming out is very high. And again, you run the risk of causing hemorrhage. What about redo or re-ETV? So this is possible after ETV failure. Decision to perform re-ETV depends on the age, etiology of hydrocephalus, what you find on imaging, and the duration between ventriculostomy and failure. Now, in certain cases, repetition of the ventriculostomy as the first choice is recommended. And this is especially for early failure due to technical failure. So, for instance, inadequate size of the stoma or unperforated liquid membrane. And you can usually see this when you review the video of the surgery. And interestingly, though, the success of re-ETV has been found to be higher in cases of late repeat ETV than the early repeat ETV, because obviously the flow of CSF has been pretty good with the initial ETV. What causes the need to redo ETV? Well, it's multifactorial. There could be a malabsorptive component. There could be complications such as hemorrhage or infection, or the technical failures that I mentioned earlier. There's actually no exact criteria defined for repetition of ETV. And so individual evaluation of each case is advised. And you can see here, there's a redo ETV here. You find that it bleeds easily because of the scarring that you can see, right? And again, in this particular case, the floor is actually very short, the space where you want to do the third ventriculostomy. But this was one of my early ETVs. That's why the video is not very, very good quality. But you can see, we managed to do it. And even then, at the end, you can see the basilar artery is pretty close. But this one was a very successful re-ETV. So when you look at difficulties, the thing is, no difficulty can discourage, no obstacle dismay, or no trouble dishearten a man who has acquired the art of being alive. So difficulties are but rare, are dares of fate, obstacles but hurdles to try his skill, troubles but bitter tonics to give him strength. And he rises higher and looms greater after each encounter with adversity. So what I'm trying to say is difficulties does not make you want to give up. Looking at the management part, so I think definitely learning how to do it, ETV has this initial steep learning curve. And the difficulties become less difficult as one becomes familiar with the variations in ventricular anatomy, the use of the various equipments for neuroendoscopy, and getting used to the hand-eye coordination for performing an ETV and the need to work in a 2D environment. So I think it's very important that if you want to learn how to perform an ETV, you should attend one or more neuroendoscopic workshop. You should be familiar with and learn to handle the necessary equipment, the endoscopes, camera, light sources, instruments. You should definitely listen to lectures on endoscopic anatomy, indications, complications. You should practice on models, right? Do simulation. I would advise also watching multiple ETV videos, even though they can be quite boring after a few. And more importantly, you should assist an expert in performing the surgery many times, and then do the so-called simple cases as a start. Obviously, preoperative imaging, patient selection is important, right? So thorough inspection of the anatomical relationships of preoperative MRI is essential. You need, as we mentioned, you need to have some preoperative detailed knowledge of the floor of the third ventricle, location of the basilar artery, and the anatomical variations that may be seen on the scan. Right, so one of the things that we mentioned earlier was that a pre-point time interval, generous one, is usually acceptable, right, as a way to do this, right? And so, right, you should only do the reduced PPIs when you gain much more experience in endoscopy. And also you need to have as much imaging as possible, so things like 3D sequences with multi-planar format, reformat images not only help you to see liquid membrane and other membranes in the pre-point time system, but also maybe the reason for failed ETV. For instance, look at this case, it looks all right here, but then when they do the sagittal views, you find that actually there are actually membranes here that, and these are the ones that if you don't look carefully, right, and don't treat them, if you can, you will lead to failure. So basically, proper surgical indication, patient selection is essential to reduce difficulties, right? And the surgical risk in ETV is higher than that of shunting. So you should avoid unnecessary trials of ETV, right? And complications are rare, but can be devastating when it happens. And so a routine ETV can become a difficult one if the surgeon is not experienced or does not pay attention to details. Right, so patience and perseverance have a magical effect before which difficulties disappear and obstacles vanish. So I thank you, and wish you all to stay safe. And don't forget the postpone the ISBN meeting and the IFNE Congress to sometime in November next year. Dates are not out yet, but we hope that we can see you there. Thank you very much once again.
Thank you, Wan Tew, for this excellent presentation. I think you made so many things so clear to us now that we have heard your talk. And I would agree with you that the most important thing is the pre-operative evaluation of the conditions, particularly the imagings. Half of the complications and half of the problems which you're going to encounter during surgery can be actually predicted beforehand by having a good assessment of the MRI scan, and then a case selection is another important thing to have. Did you or do you, whenever you go into it in thinking a straightforward or not a straightforward ETV, are you ready with the alternative methods like aqueductoplasty in case the ETV fails, aqueductoplasty, or even perforating the lamina terminalis and making the alternative arrangements while you are there during surgery? Do you really plan it out?
Okay, so I select my cases carefully. I don't just do every case, even if it seems possible. Like the videos that I have on the myelomeningocele, I've never done a single hydrocephalus myelomeningocele third ventriculostomy because I don't believe that the risk is worth it. So I think one of the most important thing is, you look at the ETV success score, because I think that's a very good guide. And for me, anything less than 60%, I won't even try unless the family absolutely says they want us to try. The other thing is, once you make a ETV, you're attempting an ETV, if it fails, right? And for me, I'm much happier to just abandon the operation and do a shunt, which has a very low morbidity, then try to actually treat the hydrocephalus. Certainly, I would not try a aqueductoplasty because a lot of the cases that we do are actually for pineal region tumors, and therefore there's no way you can do a aqueductoplasty. We actually just biopsy the pineal tumor. And I've never actually done a anterior laminoplasty, and that's a laminoplasty. In fact, I think the pathway that we use, the projection, it probably will not be suitable for anterior laminoplasty as well. So I think for me, it's very clear when you decide that you want to do ETV, you go ahead. If it's not going to be successful, the risk is too high, I would just abandon the procedure because it's not, for me, it's not worth it to actually have the patient die on you or end up with a catastrophic thing. Because don't forget, hydrocephalus is, it's not life-threatening. Immediate life-threatening, right? Patients can survive and do survive with shunts for years with no problems at all. But I think, if a patient has a good chance of succeeding in the ETV, I would go ahead, especially if your indications are correct. So I think that's a very, to me, the so-called philosophy that I follow quite clearly.
Sir, your voice is low. Can you increase your volume or come closer to the laptop?
I'm using a mic. So can you hear me better?
Now it is clear. Yes.
It was hanging far away from me.
Yes.
So let us talk to the panelists. Sandip, are you around? Subodh. Subodh?
Yeah. Yeah, sure. Yeah.
Unmute yourself. Okay. Do you have any suggestion, all those patients who are difficult, for the ETV prediction? How do you plan your surgery? Do you really go into it and try and do it? If you can't, then you come out or you try other means?
Part of my talk is about the lamina terminalis third ventriculostomy also. But as Dr. Seow told, if the patients we counsel, ETV success score we take into consideration, we have it on OPD. We counsel the patients that this patient may have a 50 to 60% success rate of an ETV if they're okay, because preoperative MRI studying is very important. And if the patient relatives are convinced, because nowadays, because they are so aware, they have read about endoscopy and then they come to us, many of the relatives. So if they're convinced that yes, we may land up in a second surgery in a month, then we do it. But yes, intraoperatively, if the challenges are very high and we think if the risk is high, we don't do it. We abandon it. It's better to abandon than to land up in a problem. It's a fairly, as Dr. Seow told, it's a fairly benign condition. I still consider it's a benign condition, which you have to take care of the intracranial pressure, and nothing more heroic in that. So if you can take care of the intracranial pressure, and if that child requires a revision shunt later in life, I tell them that if that child has grown up, this happens especially in infants less than 1 year. And if the child grows up and requires a shunt revision later in his life, we tell that then we can try a ETV then instead of doing it now.
Settle it with the shunt now. Ramesh, your comments?
Yes, sir. Routine cases, I don't think so there's any problem because most of the indications and contraindications are very fair. But the only problem is like in my practice, I do get a lot of infective hydrocephalus cases and post-hemorrhagic from the referrals from the neonatal patients. The challenges with infective is even though it is not a multi-loculated hydrocephalus, how to start, either to start with the shunt, because most of the infected cases, they fall into the worst score of the ETV success score. It suggests that you need to go for a shunt, but invariably shunt is going to get failed. And I've seen worse complication with the shunts with the infective cases. So my practice is if the child is less than, like he's older than 3 months age, I give my trial first as an endoscopy if there is no absolute contraindications, like whatever the unfavorable anatomical landmarks. I start with ETV. If that doesn't work, then I will go for the shunt or some other alternative procedures. Correct. So mostly in the below 3 years of age, 3 months of age, if it is a bleeding or infection, I tend to go with the ventricular subgaleal shunt as my first resort before I do the like betterment of CSF analysis and like MRI scan of the patient is favorable for doing a ETV score. So that's how I go by the age for the pediatric cases. By adults, I think it's invariably the ETV is my first choice to go ahead with the uncomplicated hydrocephalus.
Perfect. Now, before we go to the participants and take their questions,
Suresh, I may just make one point. Sorry, I was there. I didn't run away. I just went off for 1 minute to tell Atul that I'm in the other meeting.
Okay.
Just a point I wanted to make. I completely agree with what Wan Tew said about when I started doing this many years ago, it was an ego issue as well, and I thought I must do this ETV. Everybody else can do this. So even if I had difficulty, sometimes very little space, but I would still say, oh, I think I'm going to try this because I have to do it. But now increasingly, and I have had a lot of interaction recently in webinars with Abhay Kulkarni. And if you hear his publications and what he talked about when he came to Calcutta for the meeting in February also, in fact, shunts are not that bad as we thought they were. So if I agree with Wan Tew, if I feel that this is difficult, it can be done. I just don't struggle. I just do a shunt. And for our patients, parents are much happier if you tell them that we've done something that will work, rather than you tell them we've done something. If it does not work, then you come back after a few weeks, we'll have to do another procedure.
Absolutely.
So, I think increasingly I feel now that if there is any issue about ETV, I would do a shunt. And of course, I completely agree with Ramesh about the ventricular subgaleal, because, I've been a proponent of that for many, many years. And the only difference is that I would do an endoscopic breakdown of fenestrations at the same time as I do a VSG shunt. So I break down as many fenestrations as I can when I do the VSG. Can I ask a question to Wan Tew?
Yeah, sure, go ahead.
I was going to ask you, do you think there is a role for doing ETV with flexible endoscopes, not rigid endoscopes, given that a lot of people now around the world seem to think that the ETV works if you combine it with the CPC? Should the people who are on the beginning of a learning curve learn to start doing ETVs with a flexible endoscope rather than a rigid, like we always learned and we did before. I know Subodh uses a flexible a lot, but most of us started life with rigid. And now if you have to do CPC, should you start with flexible so that you can combine it with the CPC whenever you want?
Actually, if you have an opportunity, you should learn how to use both. Right? Actually, I started with a flexible years ago. In fact, the first neuroendoscopy course I attended was in 1993. That's a long, long time ago. And flexible scopes were then. But of course, the quality, the images that you get are not as good even today. Right? So, except for now, of course, the new video endoscopes, because that you have the camera at the tip, you're going to get very good quality images. I think that's the future, because the rigid has got its limitations. So I think if you have an opportunity to learn how to use a flexible endoscope, you should. And yes, of course, if you have a flexible endoscope, you could do a CPC much better than using a rigid endoscope. So if you have the opportunity, yes, learn, because who knows, your rigid endoscope may get damaged or not working, and you started the case. Of course, you shouldn't start the case until you have checked your scopes. That's one of the rules that you must do. Right? Check your whole system, check everything before you start. But it's nice to have a flexible endoscope there. Like for instance, when we do pineal tumors, you want to biopsy the pineal gland, pineal tumor, right? Sometimes you cannot see the pineal area with a rigid endoscope, and either you change your burr hole and then come from a different direction, or actually just put in a flexible endoscope and tilt back and actually take a biopsy. Although the only thing that pathologists complain is that the amount that you take is so minuscule. Yeah.
Thanks.
Sir, Dr. Chatterjee, can I add to this question? Sir, will you permit I can add to your question, Dr. Chatterjee?
Yeah, sure.
Sir, I think there's no controversy for indications for flexible scope and the rigid scope. Both have specific indications and they have their own space. So it's not that we are going to replace the rigid scope with the flexible scope, because flexible scope, like Subodh, I was using for the last 12 years, the flexible scope, the indications are very, very clear. Like if you have a narrow foramen of Monro, your floor of the third ventricle is good. You can use the flexible scope to do a standard third ventriculostomy. Predominantly, the flexible scope role is when you have a difficult standard third ventriculostomy, or when you're trying to work on the posterior third ventricle area, especially the aqueductoplasty or biopsy of the third ventricular tumors, or multiloculated hydrocephalus, where you want to reduce or desize the disease pathology. These are the specific indications for the flexible endoscopy, not to use a flexible endoscopy as a routine replacement to your rigid endoscopy, because rigid endoscopy, we do the 90% of the work, the rigid endoscope only. The flexible is having its own role and indication provided in these difficult situations. So there's no question of replacing the rigid with the flexible. And second point is CPC. So even though it is talked a lot about the CPC, now people are saying that choroid plexus, we can't use the CPC as a routine case in everything. Mostly the gross hydrocephalus in the neonates or infants is the one indications to do the CPC, not in a routine ETV cases where you add the ETV along with the CPC. These are probably the recent discussions going on in literature, I think, sir.
Thanks, Ramesh. Thank you very much.
My saying this, now the current publication from Kulkarni himself, is that ETV in infants and shunts work exactly the same. So there is no difference between function of ETV and shunts. It's only when you combine it with CPC that they do better off than shunts. This is his current publication. This is why I raised the issue.
Okay, sir. Okay.
Absolutely right. Yeah. Suhas, are you around?
Yeah. I had two questions for Dr. Wan Tew. One is, what do you think is an adequate size of a stoma? And second is, do you use an Ommaya reservoir sometimes whenever you do ETVs, occasionally at least?
Okay.
Do you have indications for Ommaya? Yes. Yeah.
Okay. So for the size of the stoma, actually, for me, I use a little lota, or in the past I used to use the oiscope. The diameter is about 4 millimeters, and actually for me, if I can put my scope through the stoma, that should be adequate. I mean, so by the time you actually can get it's about half 5 millimeters. So I think, and so far I've not had huge problems with that, as long as I can put the tip on my scope. So that's the way I gauge whether my stoma is adequate. Do I use the Ommaya? Actually, the answer is yes. I use the Ommaya virtually in maybe 80% of all the cases, because you never know when you're going to have a problem. Although we live in Singapore, my patients don't go away very far. But actually what happened was that, sometimes because, so routinely I follow up my patients, at least once every 2 years I see them. In fact, just towards the end of last year, I actually had one patient that, actually we did a ETV very well, follow up for 10 years, no problem. Then he disappeared from follow-up until another 10 years later. Now he's 20 years old. He comes back with severe headache and he goes to the children's hospital, but because he's 18 years old, they sent him to the adult side. And then, nobody knew what it was. They saw a reservoir, they thought it was a shunt, but they couldn't find anything. And, finally they found me and they called me, although by the time I got to him, he was actually comatose, and all I did was put a needle in and I reduced the pressure. And actually it was okay, but actually he didn't do very well because I think the period of obstruction was too long. And, ultimately the parents decided not to do anything. So this is a case of most likely a delayed stoma closure. So I think in cases that you get, so I think, having a reservoir actually is a way to try to prevent, bad things from happening. Unfortunately, in this case, even though he had a reservoir, but because we use a very small reservoir, the rectums, in an adult, sometimes it virtually cannot feel. But I would say that based on that case, most patients now today, I would put a reservoir in. It's very simple. It doesn't cause any problems. And right, it's a reminder to patient that actually they have had surgery, because you never know when the stoma is going to close.
Absolutely right. So I think, okay, Suhas, I think you have not told us, what is your take on the difficult looking ETVs? How do you deal with them?
No, I mean, I'm very clear. I mean, whenever I feel that the ETV is not going to succeed, I do not challenge myself much, especially in the infants. If at all, because I don't want to waste the baby's time using an ETV and going for a ETV, etc. I put a shunt and then I tell them that at some point I can go ahead with an ETV. So I don't feel that at that point. It's a very precious time.
Sorry, can't hear you.
Signal problem.
And admissions doesn't make sense. So I straightforward. No, hello.
Yes.
Hello. Yeah. I mean, whenever I have a bias towards success of shunt more than ETV, I suggest that I would for a shunt overall, so that I don't waste the baby's time.
Sandip, how do you deal with this problem? Do you put the reservoir just in case it is required later on? How do you
I personally do not use a reservoir, because I feel that one of the reasons why an ETV works is if you can build up sufficient pressure in that third ventricle. So I like to seal the hole, the burr hole completely, and generate the same argument that people initially used to do lumbar punctures to reduce the pressure distal to the ETV, because I think it's ultimately the pressure gradient across the ETV hole that you've made that keeps it patent. And if you keep a reservoir, you keep a burr hole that is open, then I feel somehow that you do not build up sufficient proximal pressure to keep that open. So I don't keep a catheter or any form of reservoir. But I take Wan Tew's point that this is it is a method of doing something as an emergency. But then you've got an open fontanelle in infants, and that's always available for an emergency. So I don't, as a matter of routine, put in a reservoir.
Sandip, actually the reservoir in my cases, they actually close up the burr hole nicely. It's not because it's just a reservoir.
Yeah, I take your point. I know we've had this discussion for the last decade or so, but I just never got myself to do it, and I've never found a reason to do it yet.
Okay, I think we'll take questions from the participants. There is one question about the role of ETV in TBM, tubercular meningitis. So, what do you say about ETV in TBM?
You're asking the right person.
Yeah, I'm not asking. You're asking the wrong person, because actually I have very little experience with TB. I think Sandip is.
Yeah, we have got a lot of people with great experience, but let's see, what is your experience?
Actually,
what do you think?
First of all, actually, the number of TB cases, TB meningitis in Singapore, I think I can count with one hand, right? So, and most of them are in adults. I only had 2 cases of tuberculous meningitis in the last 15 years, and all these are interestingly not they're actually the result of the kid has immune problems and actually reacted to the vaccination, not to TB. So I don't have any assistance. I mean, of course, I know about it in what the group in South Africa say and all that sort of thing. But I think I've heard enough lectures in India especially from Sandip, to say that every case of TB meningitis is an obstructive hydrocephalus. I have a bit of doubts about that, but Sandip, you're the best person to talk about this.
There is some truth in this. Subodh, what do you say?
This thing is very clear. In the tubercular meningitis, I get a contrast MRI done. If there are enhancing exudates, I don't do ATV. If there are no enhancing exudates, I do an ETV.
You don't even try once and see whether it works?
No, in enhancing exudates, because I feel the enhancing exudates, the inflammatory process is solved, they'll go for very rapid, early closure.
So you believe in this acute and chronic?
Chronic, yes. Chronic way I will do, not in the acute.
Not in the acute. Ashish, you haven't said anything about it.
Well, I mean, thank you very much. I want to congratulate Professor Wan Tew for his beautiful lecture. I've got 2 very naive questions. First of all, ETV in spinal dystrophism, I feel that it doesn't really work very well, and I burnt my fingers quite a few times. And I would request his opinion on this, because now I have better chosen to do shunts in sort of hydrocephalus with spinal dystrophism. So that's number 1. And the second question, which would make everybody laugh perhaps, I would ask you, how do you make the puncture on the floor? Because when you read the literature, you see somebody even thrusting the scope through the floor. And knowing the anatomy in different ways, what is your take on making a hole actually? Some people use sharp things, some people use blunt sort of tubes, some people even thrust the scope. So I would be interested to know that, because when you thrust something through the floor, which I have heard the big experts talking about, that makes a very ragged margin, and really how does it work? Sometimes it creates a doubt in my mind. So any take on those 2 points?
Okay, so first of all, ETV in spinal dystrophism. Again, that's something that, even though I showed quite a few slides, those are slides of Professor Taborini in Rome. I personally have not done a single ETV in any of the endoscopic patients, because most of the time, they're hydrocephalus, they're actually less than 6 months of age anyway. So maybe you might want to do them at a later stage. So most of the, where the shunt doesn't work and all that. But even those cases are really, really difficult. And so I think we don't see more than 2 cases of spinal dystrophism in our country every year. So, the numbers are actually quite small. So yes. And of course, when you look at the ETV success score, actually it's less than 50%. So again, that's to me, one of those things that I do not do. Okay, so the next thing, how do you make a hole? Right. So for me, what I've shown in the slides, okay, I use a blunt probe, and usually that's the monopolar probe in the endoscopic side, because it's nice and blunt, and you don't turn on the diatomy. You just use it as a blunt tip to put a hole, and usually that works very well. Then how do you open up the hole? The hole that you make with the endoscopic probe is big. I mean, the monopolar probe is big enough to put in a French 3 Fogarty catheter, and that's enough to blow up. Now we use a round Fogarty catheter because that's cheap, easily available. The double balloon one, which Christians and Rose have invented, that's very expensive, and we don't use it here. But it means that you have to, really play with the balloon quite a few times. I think the original idea of putting the scope in to make the perforation bigger was actually done when I think Charlie Teo and group, when they first described how they do endoscopy. I mean, it looks barbaric, sounds barbaric, but I mean, it worked. But of course, today you have better equipment. There's absolutely no need. I think the other one that may be quite useful is the Dept forceps, where where the irregularities are on the outside of the catheter and not on the forceps, not the inside, so that you don't grab anything when you put it in and open it up. So I mean, these are simple tools that are easily available, and I don't think there's any magic in it. Certainly, I do not use monopolar or diatomy to open up. And even when people talk about using lasers, you know, it depends. I mean, there's some papers in the early days, I think in probably before the 2000, where people started using laser. And again, if you have a basilar artery just below the floor, your risk of actually of causing a hemorrhage is much higher if you use a laser or if you use a diatomy, because you can damage and cause a tear. So I think blunt probes are probably the best way to make a hole.
I've been trained by one of the very senior neuroendoscopists of the country, Professor Mazhar Hussain. Now, he taught me, and it has worked very well, is using a cut a Fogarty catheter with mild beveling. So it gives some sharpness as well as it's less damaging. And you make a very nice, neat hole just closer to the posterior tubercles, and then gradually then expand it, and then go in and then sort of make a bigger hole. So that's the way I do it. Until now, I didn't have to struggle anywhere. It just goes very smoothly. So that's the way I do it. So that's why I asked this question.
Very good. Yeah. Wan Tew, there are few cases where you know the floor is very rubbery, kind of inconsistency, and it's very loose. You know, so when you push it, it goes all the way down in the prepontine cister, and when you leave it, it just comes up. Those are the floors which are very difficult to perforate.
Yeah. So that's
and sometimes you need to have a sharp instruments.
Yeah.
So what do you suggest about that?
So I don't like to use sharp instruments. So what I actually do in those cases is actually I push it, I get the floor and I push it against the tela tesica, because that actually gives you enough bite to just make the hole there. Yeah, and I think I showed that in one of the cases in the slides that I showed, and that's usually enough. Of course, there are other people have other ways, but and there's even, I think, like for instance, there used to be a suction cutting device that you can use. I think Groten Hose, that's quite nice. But I mean, you don't need to go and buy any expensive equipment. I think whatever we have usually is more than enough.
Ramesh, do you suggest anything for those loose floors which are really thumping up and down all the time and very difficult to perforate? Do you suggest something?
No, sir.
You have to unmute.
Sir, can you unmute, please, sir? Unmute.
Sir, sorry.
Okay, sir.
Sir, you can use a fine suction to grasp it to that, and use a flexible fine tip scissor to cut that one, because you will be pushing too hard that one. So if you make a small hole, you can pass your Fogarty catheter through that using a small scissor, fine tip scissor.
For some cases, what you can do is just increase the irrigation. Once you increase the irrigation, the flow remains steady. It doesn't flap more. Then you can do the procedure. If you decrease the irrigation, it keeps on flapping. Slightly increase the irrigation, the flow remains steady, and then do the procedure.
Anybody else has the different way of dealing with this problem?
I have used a biopsy forceps when the flap is towards us, you know, just to hold it as. Then it's already clear of the basilar already.
Correct.
Yeah.
And then twist it off.
Yeah, you can use the suction also. The suction also does the same thing actually. Yeah.
Wan Tew, you talked about the interthalamic connections, and sometimes when they are big enough, you know, they really obstruct your instruments to go in and do the fenestration. How important is the interthalamic connection? People talk about, you know, incising it and make a room for yourself. Do you agree with that?
Okay, so if you're just purely doing a third ventriculostomy, most of the time the interthalamic adhesions don't actually block your way to the floor. But if you're actually going posteriorly, going to look for the aqueduct, going to do a pineal lesion, it will block your way. And so you have to decide. But I've done a few, I've actually cut a few, and I've not found it to be a problem. And as I showed the paper just now, you know, again, this other group also, they do it. And I think before I started, you know, cutting, actually, I did ask a couple of Japanese colleagues, and they say they do the same thing, although, you know, there's very little publication on this. I think it's probably safe to actually cut and not cause any neurological problems.
Partially divided.
I think we should take up some questions if I have. So there's question from Bangladesh, Dr. Haradhan Devnath, who has asked about indications and complications CPC. I think that's not in the purview of this webinar here. So I'm not taking that question. I'm sorry about that. Now, the other question, of course, is again on tubercular meningitis, and the question is from Harshad Parekh. So in India, we encounter a lot of cases of tubercular meningitis with hydrocephalus. Do you all advocate ETV? I think that point has been already discussed threadbare. And as shunt block rate is high, so what are your views? I think we have dealt with that also, so that is taken care of. The other
question, one question is, sorry, you have one more to ask?
What's the success rate of patency of ETV in tubercular meningitis case? Again, I think it has been more or less discussed, and we have discussed about the situation in acute tubercular meningitis versus the chronic phase. So that has been taken care of.
So one question for you is that, in many cases, you may find that the foramen Monro is small, very small to enter with all your scope as well as the instruments. So in the cases with the smaller foramen Monro, how do you really do the ETV safely?
Okay, so like what Subodh say, you can use a flexible endoscope. But what I've done, and I've only done it once, is actually to do the ETV above. In other words, actually you have your end of the endoscope just in front, just on top of the small foramen Monro. You can still see, then you extend your instruments through it. But it's very hard because it's deep inside and it's quite dangerous. And my suggestion is probably just abandon it and do a shunt, right?
I agree with you. Recently, I've come across with this similar case, and I was really unable to go through to have the energy to go into the smaller foramen Monro. But then I just did the septostomy and went to the other ventricle and found the way to the foramen Monro much simpler from that side. So sometimes if you are lucky, you can find a way out it. So you should explore all the possibilities before you really come out.
That brings us to the end of this talk. We have to switch on to the next talk.
All right. So I would invite Dr. Ashish Pathak to take over from here. Ashish.
Thank you very much, everyone.
Pleasure. Thank you.
Thank you very much.
Thank you. It's a great pleasure to invite Dr. Subodh Raju to give the next talk. And Subodh Raju, as I see him for a long time, he is excellent, enthusiast. He has a lot of innovative ideas, and personally, I like him very much. My heart. He's affiliated to the Institute of Neurosciences, Apollo Health City, Hyderabad. And he is also with the Rainbow Children's Hospital. He's got special interest in hydrocephalus, pediatric neurosurgery, TBI, neuroendoscopy, minimally invasive surgery, minimally invasive spine. He's got a lot of publications, and he's faculty to various endoscopy workshops. And he's one of the very active and prolific hard worker in the Indian Society of Neuroendoscopy and Pediatric Neurosurgery, and EC member of that also. We are proud to have him. So, and he says neurosurgery is art, passion, and compassion. That's his philosophy. I enjoyed that statement. So both now everything is yours. Please.
Thank you very much, Dr. Ashish, for the kind introduction. What all Dr. Wan Tew has not covered, the other stomies, what all we do, I'll be covering on that actually.
Except colostomy, of course.
Laparoscopy, colostomy. My slide is seen?
Yes.
Okay. So opening CSF pathways as other things like septostomy, aqueductoplasty, lamina terminalis, and those are things. So first I will take up the aqueductal stenosis, a very attractive thing. In most of the commonest cause of an Hydrocephalus standard is an aqueductal stenosis with a hydrocephalus, huge head. And so once we go to this aqueductoplasty, what are the types of aqueductoplasties? Aqueductostenosis, there is a type 1A, 1, which is characterized by a small membrane which covers the aqueduct actually, below down. Okay. And there is a pre-stenotic proximal dilatation of that. These things have a very high reclosure rates. So ideally in these situations, you should go for endoscopic ventriculostomy. The second type is a tumor or a cyst which is blocking it. And again, because the tumor and the cyst is blocking it, it can close. So if you're taking a biopsy and if you can do an aqueductoplasty, ideal thing is to post a partial stent through it, shunt or a stent through the aqueduct. There's a type 2. And the type 3 is which happens in cases of a trapped ventricle or an isolated fourth ventricle, post-hemorrhagic or post-infectious. Here also, if you're doing aqueductal stenting or aqueductoplasty, ideal is to leave a shunt inside there because the post-infective, the reclosure rate is very high. So indications are obstructive triventricular hydrocephalus, raised ICP, translucent membrane or a thin membrane obstructing the aqueduct, or there is a pre-stenotic dilatation of the aqueduct. One thing we should remember that aqueductoplasty with stenting is the procedure of choice for treatment of isolated fourth ventricle, because as I told you. So different types of aqueductal stenosis can happen due to different etiologies, starting from an hemorrhage, post-infective, post-meningitic, and standard thing. So as a rule, initially, if possible, if the foramen of Monro is large, I used to do an aqueductoplasty in all cases, in addition to a third ventriculostomy. And third ventriculostomy is standardly described. I will not go into that. So once we go into that, we can see there's a aqueductal stenosis. There was some suspicious looking tissue over around this aqueduct here. Okay, so after this opening up of the aqueduct, we took some biopsy also. It just came out to be some inflammatory tissue actually. And a 3 French Fogarty catheter and a small bit of tissue around the aqueduct only. We took it for biopsy, but it came as an inflammatory tissue only. Shoot. Next is there's another cases of an aqueductoplasty. You see, in these cases, the foramen of Monro is very large. So a standard burr hole when you make, that is sufficient to take care of your third ventriculostomy and aqueductoplasty. So if the foramen of Monro is big, adequate size with the deficient interventricular septum and huge ventricles. So as a second procedure, we used to do this. You can see this aqueductal stenosis, some amount of old blood clots are seen. And it's a type of a membranous thing. Thin membrane is overlapping that. So just passing a 3 French Fogarty catheter and just 1.1 to 0.3 cc of inflation is required of the Fogarty catheter. That takes care of this things. And you can see the inside of the fourth ventricle outside. That's the third ventriculostomy which has been done. So endoscopic. Important thing is when you do an aqueductoplasty, we should always remember what is called as the endoscopic blind spot. This is applicable for doing a third ventriculostomy only. Also, it's a dangerous feature of inability to visualize the pathway between the skin and the endoscope tip, whatever falls in between. This creates a potential space for injury to different parts of the fornix and these things. And this is the main thing which training is required. The hand-eye coordination and this blind spot, how to avoid this blind spot is the main thing the new people have to remember. Otherwise, you land up with different grades of fornix injury. It could be a simple ependymal injury or it could be a complete fornicial tear. So in these cases, you can see this is an interthalamic adhesion. This is a fornix contusion. This is one of the cases. You see the foramen of Monro is not very big in this case. It's a small foramen of Monro. So after doing a third ventriculostomy, I just wanted to see the aqueduct. It was a case of aqueductal stenosis. I went behind with a rigid scope. It's an aqueductal stenosis. So once I was trying to visualize it, this is what, though it's a venous bleed, but the stretch on the thalamocyte and the septal vein, their junction, it produces some bleeding, and you have to keep on irrigating. So without knowing, understanding the trajectory, you should not try to looking at even visualizing the aqueduct in these cases actually. These are some of my initial experiences where we used to do this, but later on I stopped doing this. If the aqueduct is not seen, it's not seen. You just do a third ventriculostomy standardly, or I use a flexible scope. So this is a flexible scope which we use. It's a chip and tip scope, and we use the mother and baby technique. The sheath of the rigid scope is still there, and we pass. This is the rigid scope sheath which is there, through which we pass the flexible scope. It was just a case of to visualize the anatomy. This is the chip and tip scope, which has a fantastic, very good visualization compared to the conventional scope. There's just the aqueduct is hugely dilated. This is only just to understand the anatomy of the fourth ventricle. The foramen of Magendie is open, both side choroid plexus you can see here. And this is the base occipital bone, which you can see through the foramen of Magendie, the choroid plexus here. These are the foramen of Luschka here. I'll show you a case later on of doing a magendoplasty also. The foramen of Luschka here, and is all round. And as you come out, you can see the colliculus also, the superior and the inferior colliculus. This is understanding of the basic ones. So this is the advantage of having a flexible endoscope. So initially you used to go straight. Now what you are doing is you're using a flexible endoscope to go through the foramen, through the aqueduct, and you can work around and inside the fourth ventricle. So why do aqueductoplasties fail? People who have done third ventriculostomy and aqueductoplasty, it is seen that the cerebrospinal fluid flow through the ventriculostomy is significantly higher than the flow through the aqueduct. So if any stomy which we have made, if it has to remain patent, there should be adequate flow of CSF through it. So if the rate of flow of CSF through third ventriculostomy they have seen is higher. This is a paper by Schroeder only, and that's why they tell that the aqueductoplasty can fail. Next comes post-infective of the trapped fourth ventricle, what you see here. There's a patient has a shunt already. There's a post-tibium hydrocephalus. There's aqueduct, and there is a closure here. There's a trapped fourth ventricle. We tried passing a Fogarty through that and opening up the cyst there. Then take a flexible endoscope to visualize. This is what we are visualizing into the fourth ventricle. This was the conventional flexible scope, which we had initially in 2000, from 2008 onwards. That doesn't have a very great visualization, but later on with the rigid, with the chip-on-tip scope, we have a better this thing. So in these cases, after doing a septostomy, what we do is we place a stent or a reservoir, which is converted to a shunt, which passes through the aqueduct and stationed in the fourth ventricle here. So this is the pre-op and this is the post-op images. These are the cases of a trapped fourth ventricle, and what you do is do an aqueductoplasty and place a stent across that. This is again doing aqueductoplasty, and this with the flexible scope, the shunt is guided into the aqueduct. You see, we are guiding the shunt into the aqueduct, and it connected to a routine ventricular protrusion. We make number of fenestrations in the shunt all along, so it drains the lateral ventricle and the fourth ventricle cyst, and it also keeps the aqueduct open. If it's possible to do a third ventriculostomy along with it, we just place a reservoir with a stent. If it is not possible to do that, then we go ahead and do a routine connected to a routine VP shunt. This is the post-operative image. You can see the stent placed inside the fourth ventricle. Here you can see that across. There's a pre-operative, there's a post-operative. You can see the trapped fourth ventricle size also has decreased. There's another case, similar case. I'm not going to, I think there's sufficient examples. So this is a case, this child had a TBM with hydrocephalus at the first year of life, had undergone a VP shunt. The child presented with ataxia for last 1 year. You can see there's a huge trapped fourth ventricle. So the difference between the previous case and this case is the supratentorial ventricular system is normal in size here. It's chinked out. So in these cases, what do you do? So in these cases where the supratentorial ventricular system is normal in size, so what we did was we did a small suboccipital craniotomy and then did a retrograde aqueductoplasty. So once you did a craniotomy, open the dura and pass the scope through here. And this is the closed aqueduct which you can see from below. This video is slightly poor. Excuse me for that. You can see that closed aqueduct. We are trying to open it with a 2 French Fogarty catheter. You can see here. The aqueduct has been opened here. So this is a retrograde aqueductoplasty, which has been also well described in literature in cases of the ventricles being normal in size or chinked, where you cannot come from the top. So this is called a retrograde aqueductoplasty. This is the pre-op image you can see, and the post-op image after 3 months. There's a slight reduction. Symptomatically, the child is fine. And this procedure also has been previously documented and described. Next comes idiopathic stenosis of the foramen of Magendie, or it's called the fourth ventricle outlet obstruction, which we see very rarely. So in this patient had an adult with a fourth ventricle outlet obstruction, and this is foramen Magendie. So the prepontine system was very narrow to do a third ventriculostomy. So I had gone inside, so I thought that let me try this out. Because of the fourth ventricle outlet obstruction, the aqueduct was naturally big. So we went through a transaqueductal. You can see the thin membrane covering the foramen of Magendie, the pulsation you can see here. So we went with the same flexible scope and opened it up with the help of a 3 French Fogarty catheter. And this is the tonsils, and you can see the pica vessels here. So this adult actually did fairly well. Till date, it's almost 4, 5, I think 6 years we have done that. As a child, patient has been doing still well. Rare cases. Otherwise, another 2 cases of foramen of Magendie, they had gone for restenosis actually. So, but this is a case where it worked well actually. The Magendoplasty or Magendostomy. So inadequate septostomy is sometimes be done because the learning technique of you're putting the scope, if you are not correct, you can land up on the other side of the ventricle. You pierce the septum and land up in the other side and you don't know what to do actually. So this is an accidental septostomy which has been done by one of my colleagues, and they called me that we have reached here. How do we do a third ventriculostomy from here? So in these cases also, you don't want a septostomy. So we have gone to the other side. You can see the foramen of Monroe should be medial here. This is gone to the other side. So we have to practically use a flexible endoscope, go through the septum and try to do a ventriculostomy from the other side. These are all salvage procedures when once you are familiar with using a flexible scope. And next comes, this point was discussed about difficult third ventricular floors actually. Intense adhesions, vascularity, very narrow prepontine system, or the anatomy at the floor of the third ventricle is not well described. What do you do in these cases? So I did have a fixed plan in these cases, but as I told, for a long time I had my flexible scope in my armamentarium. And whenever we used to do a rigid endoscopy, third ventriculostomy, and the foramen Monroe is large, I always used to try and visualize the lamina terminalis. Because we routinely open the lamina terminalis in cases of ecom aneurysm from the top. So why can't we do it from below? That was the aim. So most of the cases, we took a non-table decision to open up the lamina terminalis. We had a paper published about this lamina terminalis third ventriculostomy. For the understanding, this is the position of the lamina terminalis, and it is just above the optic chiasma. You can see here the angle. Through the same burr hole which you do a third ventriculostomy, it is difficult to see a lamina terminalis unless your lamina foramen of Monroe is very big. Otherwise, you take a flexible endoscope. And the end point of a lamina terminalis third ventriculostomy is visualization of any of the part of the anterior communicating artery complex. I'll show you. We have done around 10 cases on that actually. So both these cases, this is with the old where we have done. This is the lamina terminalis we are trying to open in the large foramen of Monroe. This is done, which is recently, we did a third ventriculostomy, not very happy. So we use a flexible to open the lamina terminalis here. This is optic chiasma you can see here. To French Fogarty catheter to dilate it. Here also you can see we're using a two French Fogarty catheter to dilate it. There's an interhemispheric fissure which you can see with some perforators of the anterocommunicating artery. Here you can see the anterocommunicating artery complex. Here also you can see. So large foramen of Monro you can do with a rigid scope. Small foramen of Monro, use a flexible scope. You want to do a lamina terminalis third ventriculostomy. Especially tubercular meningitis I mentioned because tubercular meningitis is basically a basal arachnoiditis. So sometimes the arachnoid above is free. So if you find an exudate or scarring below, you can always go above and do a lamina terminalis third ventriculostomy. These are some of the other cases. Next comes when we talk of septostomies, we can have isolated lateral ventricles, multiloculated hydrocephalus. These are cases of a trapped lateral ventricle. Trapped lateral ventricle, you can see here that the patient has already undergone a VP shunt, but this part of it is shunt. This child has presented at 11 years with episodes of transient upgaze and excessive sleep. He has undergone a VP shunt. So here we do try to open the foramen of Monro here, do a foraminoplasty. If required, we add it with a third ventriculostomy or just do a foraminoplasty because the patient already had a shunt. This is the post-op images actually. And the child improved dramatically. These are again other cases of isolated ventricles. You can see the isolated ventricle, the enlarged ventricle obstructs the foramen of Monro, and they're all benign conditions. You can see here, right frontal burr-hole we do. The foramen of Monro is completely blocked by the choroid plexus. In these cases, just do a standard septostomy. The only thing you have to remember in septostomy is adequate devascularization of the septum as large as possible. Otherwise, they will all lead to restenosis of those cases. This is the post-op images of these cases. Initial days, I used to use the reservoir very routinely, but now I use it in selected cases. And the other indication of doing a septoplasty, septostomy is in cases of colloid cyst. Whenever we do a colloid cyst excision, I always follow it with this is a endoscopic colloid cyst excision. Once you have finished the procedure, we ended up with doing a good septostomy actually. Two things it helps. If there is adhesions and obstruction of foramen of Monro on the ipsilateral side, that can close. And second time to check whether there is any hemorrhage on the opposite side. These are the two reasons why we do a septostomy in cases of choroid plexus. So this is a case of a cavum septum pellucidum with a trapped ventricle. You can see a big one. So these here also we do an endoscopic. We did a septostomy and then a shunt placement in this case. The ventricles are trapped. So basically, this is a type of it is a case of a trapped ventricle. Next is again an isolated occipital horn or the atrium of the ventricle. This child also presented with intermittent headaches. So there's a vessel which is there, we just and the choroid plexus which is overlying it. We have to just coagulate it and make a big opening on that. Devasculate is as far as possible. Then I added a septostomy to it also. We did the fenestration of this cyst wall here and plus a septostomy here. So that was very helpful in this child also. This was a 12-year-old child presenting with repeated headache. Another important part is a trapped temporal horn. This is a 7-month-old child with progressive increased height. You can see there's a trapped ventricle. The left temporal horn is completely tagged. The right side is communicating, but the left side is trapped with a thick membrane or brain tissue, actually in this case. We tried doing an opening, but I knew that this is not going to stay in cases where the thickness of the septum is more than 5 millimeters. They have a problem actually. They go for reclosure. This is what happened, reclosure and increasing the temporal horn. So ultimately we went for a left temporal ventriculoperitoneal shunt in this child actually. We have done a medial opening of the temporal horn into the cisterns in some cases. I could not find that. But so what happens in these cases? This is a case of a classical case of an arachnoid cyst, but this is the same method we followed in a child where the temporal horn is hugely dilated and the medial wall is very thin actually. So in these cases also, we went into that temporal horn and we open up the this medially we connected to the suprasellar cistern actually. You can see the medial part here. Just cut the, if you can cut the arachnoid, it's fine. Otherwise, you make an opening. If you have a neuronavigation, it's good. You can see the medial cisterns getting opened up. So some arachnoid layers still there. And you can, if you have a neuronavigation in these cases, it's very helpful actually. And you open it up and make multiple openings in that. It's a very, very effective method of treating all middle fossa arachnoid cyst actually. This is another case. So you can do a shunting of the temporal horn, or you can do an endoscopy, or you can do a marsupialization. Next comes the trapped third ventricle. This is the third ventricle which is trapped. You can see here, both the foramen of Monro is closed. There's a large cyst. There's again old post-infective, that's what we got it from the history actually. We did an endoscopy and opened it up. Cyst was fenestrated, that's all it took care of that opening up. The most challenging thing in doing septostomy is the multiseparated hydrocephalus, and is defined as multiple separate cystic cavities. Multilocular, it can be called as multilocular, polycystic, multiple septate, whatever we can call it. But it's a complicated form of hydrocephalus. Following in most common is infection in the childhood. The normal ventricle anatomy is disrupted. You can't know the anatomy. And the most important thing we have to remember is multilocular hydrocephalus has been defined. It's a progressive disease. It's a dynamic disease. It's not that once you have done a septostomy and a shunt, that's the end of it. So what are the issues in hand in these cases? The children have severe disability, intracranial hypertension. There is no standard treatment. And initially, multiple shuntings used to be done. But with the advent of endoscopy, we are able to communicate all these things and leave the child with one shunt actually. MRI is the best thing, or you can, the frontal is open on table, you can use a navigation or you can use an ultrasound. Different management options are available, but with shunting, septostomy is also a very important thing. And putting multiple shunt used to be in the previous days, but we have seen that it's of no use actually. You have to keep on revising that. And you get different types of things actually. We have done a shunt in one side after doing septostomies. After 3 months, you see the other side getting dilated. Because I told you, as it's a dynamic process. There's a 6-month-old child post VP shunt, again presented with multiple cavities. And aim was to communicate all these cavities and make it into a single cavity. So you do multiple septostomies in these cases and do it. And as I told you, do it, devascularize as much as possible. And once, oh, this media is not available. So the shunt is exactly in the previous scan I showed in the opposite side. So what we do is we draw a trajectory from exactly the opposite side and go all across, opening up different septums till we see the shunt. So what in turn what you have done is you have communicated all the cavities. Now you can see that across 2 septums, you are able to see the shunt here. So which was previously done. So open it, devascularize this septum, see the shunt, and draw the shunt into these cavities. So you have communicated it, and the shunt was a functioning shunt actually. So we communicated it and put the shunt across the pathway where you have entered the endoscope. That takes care of it actually. So multiple shunt placement is not an option. You can do in bad cases. This is a 3-month-old child, hydrocephalus, ventriculitis resolved. Did a shunt first, 3 months, raised recipe 15/11/2016. We used an navigation thing to do this multiple septations. Wherever possible, we use a navigation system. If it is not possible with a navigation system, then we use an ultrasound actually. This is how we guide the endoscope navigation. Very, very important thing to remember, some of these adhesins and septums which are formed, first of all, you should not let in too much fluid or you should not let out too much CSF to go so that there are no shifts actually. And many of these septations which happened are quite rigid. They're not very pliable, these things. But yes, they move with the fluid pulsations. So a method of knowing that the shunt opposite side is free, the septum opposite side is free, is to rapidly release the CSF and inject saline. So that flapping technique tells you that the septum is free or there is a brain on the other side. Along with this navigation, ultrasound, everything you can do this. And do the septostomy and take care of it actually. As I told you, big, complete, use your cautery liberally to devascularize the septum and then devascularize the septum and then make an opening. Then we placed a shunt across it also. Under visualization, you can pass a shunt into that actually. And guide the shunt all across. Making cavity one and guiding the shunt is the most important aspect of this. So later on, after some time, the child presented with this. After the first initial, after almost 6 months, another set of septations were there. Again, neuronavigation guided septostomies and shunt placement was done. You see, we have placed it on the opposite side. This is collapsed. The shunt is here. So you go all across from one side to the other side. This is another case actually. You open up the septations and take the shunt out from there. Then you do whatever minor cavities are there and you do multiple septostomies to that. So in these cases, the difficulties are the fluid loss and the shifting of the septums which happens. So combining navigation, intraoperative imaging like ultrasound with endoscopic is very helpful. And if the wall is not well devascularized or widely fenestrated, these things can, they can recur actually. So you have to, as I was repeatedly telling, the good devascularization, making big septostomies is very important in these cases. Concluding, trying to keep the procedure as physiological as possible in these anatomical variants and doing septostomies is very important. And some amount of preoperative 3D visualization with some, you require some amount of creativity in these endoscopic multiseptate hydrocephalus or multicoloculated hydrocephalus or trapped ventricles, you can have this actually. Thank you very much.
Thank you, Subodh, again for a very excellent disposition and covering a wide range of topics. And this was really, really very illuminative and with good examples. Thank you very much. I just have one or two questions for you. When you're doing a septostomy, let's start with septostomies. There are certain defined areas to do septostomies. It's divided into anterior third, middle third, posterior third, and things like that, depending on the disposition of the vessels and the veins. So what are the areas you have a preference? I mean, what would you sort of suggest?
So doing the septal vein is there, the foramen of Monroe is there. They're the two important landmarks you have to remember.
Yeah.
The third landmark or the third method you have to remember is what is the direction of a trajectory of doing a third ventriculostomy. You cannot be moving too much to do a septostomy actually, not to cause additional damage. So depending on these things, I can do anterior to the septal vein or posterior, depending on that thing actually.
I think the neuronavigation gives me a better guide. That's where I feel confident about it.
Yeah,
depending on foramen. So
not really required in this, but yes, if you have it, you can use it in most of the cases actually.
And you're using flexible endoscopes for all aqueductoplasties, or specifically when you have to go to the fourth ventricle? I mean,
Sir, I told you, if the foramen of Monro is large, you can do it with a rigid scope. Or you have preoperatively planned that I don't want to do a thermotostomy, I can just want to go near the aqueduct, then you don't require. But as I told you, my armamentarium has a flexible endoscope. So I do it with a single burr hole. If required, I take the flexible scope also.
You have not talked about foramen monroplasty, which is also a described technique for small foramen. Only one case probably you mentioned.
One case I showed that it was a closed foramen of Monro. I'm not very, because my fear is always damaging the fornix actually, especially if it's on the left side actually.
There are quite a few daring surgeons who have produced a series claiming that the results are not that bad. So, so that's there. Right. With this, I would request the panelists, is Sandip there, or Suhas, Ramesh, Sandip?
Yes.
That's the man. Yeah. Any comments, Sandip?
Yeah, fabulous talk as always, and fantastic cases. I have a little issue about aqueductoplasty with a stent. You know, I always felt that if you're going to leave a stent, and I know that if you're going to do an isolated fourth ventricle, the only thing that works is if you leave a stent, or if you're doing a tumor. Perhaps in type 1 and type 2, you can get away without a stent. But if you have to leave a stent and you're leaving a foreign body behind, then what harm in just doing a ventricular peritoneal shunt? I'm not talking about the ones with an isolated fourth ventricle. I'm saying when you have a membrane or a stenosis and you are going to leave a foreign body behind in the form of a stent, why not leave a ventricular catheter, which is a foreign body, and do a shunt? This is something that I've always sort of been concerned about. I think, would you think that it is best, even in an aqueductoplasty, except for an isolated fourth ventricle, where I think there is very little question about leaving a stent, but it would be better to do it without leaving a stent? That's number one. Number two, I have one case which we reported, which came up with horrendous internuclear ophthalmoplegia after doing an aqueductoplasty in a very small baby. Did you ever have any disaster, or all disasters only happened to me?
No. Answering your question number one, I told you the stent, I leave it only in trapped fourth ventricles. Very clear. It's a stent which is connected to a shunt. Because what happens in trapped fourth ventricle is the prepontine cistern is very narrow because of the brainstem is pushed anteriorly. So we don't attempt a very, sometimes a third ventriculostomy if the prepontine cistern is very narrow. So after opening up the aqueduct and opening up the trapped fourth ventricle, I leave a stent which is connected to the shunt, where I make in multiple fenestrations all around the shunt. So the catheter is draining the fourth ventricle and the lateral ventricle and connected to a routine ventriculoperitoneal shunt. Routine aqueductoplasty, clear-cut cases, I don't leave anything inside. That's it.
Yeah. I mean, the reason why I was going to ask you that question is that's exactly what we've done in a couple of cases. We've used a ventricular catheter. We've made proximal holes by using a bone nibbler and making holes on the sides, and then pushed it in through the aqueduct into the fourth ventricle. So it becomes one catheter which is draining all the way. This is exactly the point I was going to come.
Yes, that's what we do actually.
Suresh wants to ask something.
Yeah, Subodh, I'm talking about the routine aqueductoplasty when you are not planning to put a catheter or anything inside. Do you actually dilate the aqueduct after puncturing it, or dilate with the balloon, or
no puncturing? Yeah? No puncturing, sir. We just take the Fogarty catheter. Again, when I am doing an aqueductoplasty, I don't use a 4 French catheter at all. It's always a 3 French or a 2 French catheter, and pass it through it. We don't try to open it through any rigid forceps or anything. And as I told you, the 3 French Fogarty catheter with 0.1 to 0.3 ml of saline dilatation. That's all. Ask my anesthetist to observe for any hemodynamic changes. Answering Dr. Sandip's question, I had one case initial days when I had used a 4 French catheter actually. I didn't have a 3 French catheter. I had a 4 French catheter, and we had one case of this, but that was a temporary, luckily temporary this things.
But then re-stenosis must be very, very common then. At least, in my experience, if you do just a small catheter perforation and come out.
No, dilatation. You dilate it. Aqueductoplasty. Yes, yes. I always dilate it. I showed it the video. I dilate it all.
Okay, sir. So is it safe to dilate? That's what my question is.
It's safe to dilate. I told you, you have to be very careful. As I told you, 0.1 to 0.3 ml of saline only. That's all.
Is Suhash there? Suhash is there?
Yeah, Suhash is there.
Any comment?
I had two comments. One is for trapped fourth ventricle. Sometimes we connect the ventricle to the ventricle when the dome is thinned out. So that's an option in a trapped fourth ventricle. And my second comment was on septostomy. When you do a septostomy, the burr hole is usually lateral so that you face the septum directly instead of oblique. So these are the two comments I had for that talk with Subodh.
Septostomy, when most common septostomies I do when I do a colloid cyst actually. Yeah. So colloid cyst, routinely the burr hole is very lateral. So we take, as lateral as possible we take it. So that doing septostomy is easier in cases of colloid cyst. It's only when you're doing a routine third ventriculostomy plus on table you find that I should do a septostomy, then is an issue. That's all.
Yeah. And the ventriculostomy for trapped fourth, when you go transcerebellar, you have the dome of the fourth ventricle which is very thick out. You can use a transventricular pathway instead of an aqueduct. Then you don't have to catheter to it. It's very thinned out, and you get a large opening naturally. Possible.
I have not done a trans cerebral these things.
Cerebellar.
Yeah, cerebellar. My most of the thing is an antegrade aqueductoplasty or a retrograde aqueductoplasty. If the ventricles are large, antegrade. If the ventricles are small, retrograde.
If you're doing a septoplasty, you would do it from the normal side or dilated side of the ventricle?
So septostomy.
Sorry, septostomy. Mistake. Yeah.
Septostomy or
from the normal side or from the other side, because you find the bulge better on the normal side.
You are absolutely correct, but the manipulation of the scope is better than the dilated side. As I told you, you have to do a slight flapping initially before doing a septostomy. Just make the septum slightly flapping. That's easier to do it actually.
Ramesh, do you have any questions?
Sir, one question to Subodh. Thank you, Subodh, for an excellent presentation. When you're doing the retrograde aqueductoplasty, when the supratentorial ventricular system is quite narrow and you're trying to connect the fourth ventricle across the aqueduct, was there any shunt done to these cases, or we just do a aqueductoplasty and leave it?
The child already had a supratentorial shunt.
Yeah. Okay.
I just did an aqueductoplasty and left it. It's almost 1 year now. The child is doing well.
Yeah, that's fine.
Just about the multiloculated, the cysts and the changes after TBM or infection. I mean, I believe that a routine neuronavigation has to be there. I mean, it is a must. That gives you much more flexibility and confidence. Otherwise, you'll just get lost. Ultrasound, I'm not very sure because...
very good tool.
I know. But somehow you have to make a bigger opening then.
No. In cases of children, if the frontal is wide, frontal is open.
That's a different story. Yeah, I'm talking of older.
Otherwise, it's a navigation only.
Yes, the navigation is a very useful tool.
Absolutely.
Right. Suresh, you have anything to add?
Navigation gives you the trajectory only.
Yes.
Once you have punctured this thing, the whole anatomy changes. Okay. But ultrasonography, particularly when the anterior fontanelle is open, I think is an excellent.
Yeah, that's all right.
Sir, I have seen this, sir. As I told you, if you are not letting in a lot of CSF or letting out a lot of CSF, number 1 point, and these inflammatory septums are slightly more rigid than your routine septums actually. I have not really seen a very good, a very massive shift to misguided navigation system as of now.
Can we have comments from Professor Wan Tew, please? I mean, Professor Wan Tew is there or he has left?
He is there.
I just wanted to ask because about the aqueductoplasty. Actually, the reports from the European group, Hakim Hotel and all that, they actually say that you have to put a stent if you are going to do aqueductoplasty, the type 1, 2 that you talk about, because they will inevitably close up over time. So my question is, you have to go and do that. Why don't you just do an ETV? Don't go and mess around with the aqueduct.
I'm absolutely, as I told you, in some of these, like there's a posterior third ventricular tumor or these things, we just do an ETV. Okay. Initial days, in routine aqueductal stenosis, I used to do a double procedure, initial days, okay, where the foramen of Monro was large. But now most of these aqueductoplasties have been reserved for either a trapped fourth ventricle, or if I am going a transaqueductal fourth ventricular procedures, the small aqueduct, I want to do a posterior fossa arachnoid cyst. I want to deal with the posterior fossa arachnoid antegradely, not retrogradely, antegradely. Then only I go. Otherwise, as you told, you are correct. We don't do routinely aqueductoplasty in all cases.
Yeah. Okay.
We have got some questions from the, sorry, Professor Tew, you want to ask something more?
No, that's all. Only the only thing is that I think the stent in the aqueduct, usually you need to connect it all the way to the skull, because otherwise it will move, and then, you know, if you put too short a stent, it will actually move away, and then you will close back again. So
The stents, only stent?
I mean, so what they do is they, you know, recommend, like, you know, you holes on both sides, but it goes all the way up to the skull to fix it. Otherwise, it can move. And
yes. So if you can just take the reservoir and extend the tube, so it's anchored to the reservoir, it acts as both the ways. It's anchored. It will not move then.
We have got some questions here, and this is from.
Can I just ask a question to Subodh?
Yes, sir.
Just before, you know, about when you talk about post-infective hydrocephalus, we're talking about pyogenic and post-tuberculous in the same breath. How many post-tuberculous hydrocephuluses have you seen which are multiloculated?
No, not much. Not many.
I just wanted to make a small point about this post-infective hydrocephalus.
Post-pyogenic.
Talk about post-pyogenic and post-tuberculous in the same breath. They're actually completely different diseases.
Absolutely, absolutely.
Because, you know, even this question of doing an ETV in post-tuberculous versus doing it in a pyogenic, remember that all the fibrosis and adhesions in a pyogenic hydrocephalus occurs when there is acute inflammation and that the bacteria is winning over the host. You know, in TB, actually, everything that you see fibrosis, and people say, you know, when you have fibrosis, you shouldn't do an ETV. Fibrosis occurs when the host is winning over the bacteria. So the acute inflammatory process is never there when you have fibrosis. And therefore, the disease process is actually dying out when you have fibrosis producing any form of hydrocephalus in TB. Whereas it is completely active when you have fibrosis in post-pyogenic hydrocephalus. So in spite of the fact that people think there's a lot of fibrosis in the basal cisterns and basal arachnoiditis, I should not attempt an ETV. If you really think about it, you can attempt it, because when you're having that fibrosis is when the disease is healed. And you're much less likely to have a bleeding or some sort of a catastrophe than in a pyogenic hydrocephalus. And the two are completely different. It's like comparing oranges with apples when you consider doing this. I mean, I'm just saying this because we often paint the two in the same breath, but they're completely different diseases.
Please.
So one question to Sandip sir. Sir, have you seen, like, in post-TBM, I have got few cases who were shunted already from outside. Over a period of time, they developed a granuloma along the shunt tube, which is blocking the shunt. And there's a massive edema causing severe raised SCP symptoms. And that subsequently lead to small pockets happening. Suppose one side temporal horn is blocked, so it is disconnected. And if you treat this one, there is another side is going on. And invariably, they cause hydrocephalus along with the mass effect because of the granuloma with extensive edema. Did you see these cases, or what is your plan of action, sir?
We have seen that. I have seen that. I'm sure Suresh has, I think if I remember right, has a case which he showed up like that also in the past. You see, again, when you are getting tubercles that are forming in a patient, that means that this patient is actually still got active disease.
Yes.
And acute hydrocephalus or acute ventricular dilatation, I prefer to call it in TBM, is something that has a lot of pathologies. Every ventricle that is big in TBM is not because of an obstruction. And you know, if you read the article, we have written a very extensive article on this in Child's Nervous System in Neurology India as well. And there is something called brain compliance, which is completely, because remember TB is end arthritis and there is softening of the brain, and you can get very big dilatation, not because of hydrocephalus, but because there is a vascular issue that causes brain softening. So when you see big ventricles, do not always think you should do some sort of a fenestration or put in a shunt or something like that. You can have very low pressure in that ventricular system, and we've shown it. There's an excellent publication that Professor Rajshekhar did where they also showed the same thing. That you have big ventricles and you've got tubercles, and you measure the interventricular pressure, it's very low. And yet the child is doing very badly, so everything is not the same pathology in TB, but if you have that and you've got an obstruction and the pressure is raised, obviously then you have to think about doing fenestrations and putting in a shunt again. In our series, ETV had the same success rate as shunts in post-tuberculous hydrocephalus, and both were pretty dismal, I may add.
Sandeep, I have to just share with you, there are two situations where I had to open up the basal cisterns because of intense arachnoiditis and adhesions leading to visual compromise. And we thought that we'll give some relief by trying to sort of dissect in that. So seeing the situation, the way the whole basal cistern gets plastered in post-TBM cases is very difficult, and taking a point that we should not consider that we should not try for ETV in this case. Once there is arachnoiditis in the basal cistern, it's not an easy thing. It's something like, you have spinal arachnoiditis. You have no CSF at all flowing anywhere. So that's exactly happens in TBM also. So again, to try an ETV, okay, you can make a fenestration, but how far that CSF is really going to percolate through the sort of meshes of the adhesions? That's a very difficult question to answer.
Lamina terminalis.
Yeah.
And also
yes.
And Ashish, and also the CSF absorption defect at the arachnoid granulation level. Much more in TBM than pyogenic, I think. And that also counts when you're talking about the...
We have a couple of questions here, which we just need to answer so that, the participants also feel contributing to it. There's one question which says, ETV in Dandy Walker, especially in variant of solitary posterior fossa dilatation. What is opinion on that, Subodh?
ETV in Dandy Walker,
especially in variant of solitary posterior fossa dilatation. Any comments by anybody, in fact?
Yeah, I mean, the results have not been very great with ETV in these cases, actually.
This is Sushant Kumar Das from Bhubaneswar.
Wan Tew, what is your take? What is your comment on this?
I think there definitely has been reports, and I think the European group, like our friend Tamburini and group, they actually have done quite a lot of ETV. They say actually the success rate is quite high. Personally, I've never actually had to do one, and I'm not sure because I think it's a much more difficult. And you can see the anatomy of these sort of cases; they're not exactly the bread and butter type of flaws, and so I think you have to probably be doing quite a lot of this to actually be able to do a good one properly. So, I mean, I think it depends. One of the things that you also notice that not every case of Danny Walker actually have hydrocephalus in the first place.
Absolutely, right? Absolutely.
Yeah, so I think each and every one you actually will decide. And some of those that present, actually, they are actually very young as well. And again, you know that there are poor outcomes and you might not want to actually do this operation until, again, the same thing when they're older. So I think it's something that probably can succeed, but I don't know where on the ETV success score actually this thing actually is.
Hello, are we on?
Yeah.
So I think the next question has already been answered. The question was, I believe flexible scope is meant for seeing, which is not the answer. It is also used for fenestration. So that has already been answered. So I think that brings us dot on time.
There's one more question.
Yeah.
Is it possible to assess the dimension of foramen of Monro
Yes.
Yeah, it is possible to assess the dimension of foramen Monro. We should assess because you want to use a standard lotoscope or a mini lotoscope for doing that. And if the foramen Monro is small, you have to plan your trajectory. Otherwise, you will end up in damage.
And of course, you need special sequences. The best is to use the CISS or equivalent to actually do that.
Absolutely right.
I think that brings us to the end of this wonderful webinar we had today. Very educative, very much interactive discussion there. And I think everybody has enriched themselves by discussing all these important points and issues related to the two important topics. And I thank both the speakers profusely for sparing their valuable time on a Sunday to be with us, and of course the panelists who have been very much vibrant in the discussion and raising very important issues which were discussed very well. And not but the least, last but not the least, I thank our president, Dr. Suresh Sankhla, for sort of organizing this. And with this, I request Mr. Nayak to close the session.
Yeah, thank you very much. I think we had a phenomenal response to this first webinar series 1 of Neuroendoscopy Society of India. We had more than 300 logins from 5 different countries and 26 of them from abroad. So on behalf of Health and You, I would like to first thank Professor Dr. Suresh Sankhla for conceptualizing this and starting this webinar series and giving us an opportunity to carry this. On behalf of Health and You, we would like to thank our international speaker, Professor Wan Tew Seow, for coming to India and giving this series, although virtually, giving your speech, and Dr. Subodh Raju, who was excellent as usual with his examples, cases, and his technique. I would also like to thank the discussion panelists who added value to these topics. Dr. Sandip Chatterjee, as usual, with his insightful questions wherever he is across the globe, and Dr. Ramesh Theegala and Dr. Suhas Udayakumaran. Thank you very much. This entire webinar session was moderated by Dr. Suresh Sankhla and Dr. Ashish Pathak, both President and Secretary of Neuroendoscopy Society of India. On behalf of Health and You, would like to thank all of you for allowing this to carry this webinar, and thank all the audience. In spite of Sunday, they logged in huge numbers. We'll be back with you with our announcement of Series 2 in this webinar series. And this webinar will be available tomorrow on our DigiNeuro channel of YouTube. So if you go to YouTube and type DigiNeuro, you will see this webinar as well as the host of webinars that we have conducted in the past, more than 35 of them. So this is Deepak Naik signing off on behalf of Health and You. Please continue to support Health and You products. Have a... Yes, sir.
The next webinar is on 13th of September. Again, a Sunday. We have deliberately chosen Sunday so that everybody can have a good lunch and then enjoy their postprandial sleep with us. Thank you.
Okay, great. Thank you so much. So you have the date for the second in the series of this webinar. Thank you very much. Have a good night. Thank you. Thank you.
Thank you. Thank you
Thank
all.
you.